Hi, everyone.
Hi,
Hello.
hi, hi.
Hello.
Gosh,
Hi.
spontaneous, no time to prepare here. Let me just shut the door behind. I'm so
So,
sorry. I thought it was in an hour. So here I am,
yeah,
all relaxed,
no
not
problem. I think
prepared.
there's some issue. I'd send a Google invite so that it translates into your time zone adequately. But I think it's all okay. So
Yes,
before you came, we were just chit-chatting on some of the common questions which are coming from people. So I think we had an opportunity. So Dr. Penny,
yes.
I'm Shashikant Iyengar, one of the co-organizers. Me and Anup, we are both organizing this second Metabolic Health Conference of India. We had the first one in October 2023, and now we have the second one. So
Yes.
the programs focus more on the applications of low carb and ketogenic or even carnivore diet in the space of metabolic health, neurological health, mental health, CKD, cancers, diabetes, autoimmune conditions also. So we had carnivores also coming in and speaking. So,
Mm.
so I'm Shashikant Iyengar, a metabolic health coach India associated with D-Life, and I have with me Anup Singh. He is the originator of D-Life, the India's oldest, largest, and biggest community. He will talk about D-Life in a couple of lines. Anup,
Yeah, it's just a platform now where community is just a small part. We started with community in 2014, and now it has grown to the extent that we are now offering, certification courses. And there are about 250 success stories on the community. And if you include all the, network of coaches, it's 3,000 plus.
Wow.
And the USP is that it has about 2,000 Indian low carb recipes. So in that context, we are the largest Indian low carb platform in the world. And
Amazing.
I myself am a diabetic type 2
Yes.
from 2011 and on zero pills, running almost 14 years now, going to be completing 14 years and no pills. So in
Wow.
short, in my estimate, I've eaten about 8 kg, avoided 8 kg of those pills that I had to eat if I was
Yeah.
on carb.
Yeah.
Thank you. Welcome.
so
Fantastic.
yeah,
So good.
so that Dr. Penny, we have exactly 33 minutes left. We'll have to compare that 45 minutes to 33
Quick,
now.
quick.
And we'll
Yeah,
do
yeah.
it, no problem. So I'll give a quick
Yeah,
introduction.
yeah.
Yeah.
Dr. Penny Figtree or Penelope Figtree, graduate from the University of Sydney with the first class honors in 1993 and is a fellow of Royal Australian College of GPs and on the scientific committee of the Australian Metabolic Health Society. She began focusing on low carb and ketogenic nutrition to treat metabolic syndrome back in 2018. As a co-joint lecturer at the University of NSW Medical School, she has completed research projects, including one on the CKD or chronic kidney disease and very low carbohydrate diet with a poster at the Australasian Diabetes Congress back in 2022. By using therapeutic carbohydrate restriction, Dr. Figtree allows to stop medication and watching people regain health. So she lives in Australia with a husband and three children. So please tell us why, how come you came into this low carb world?
Yes. Well, I discovered this 2017, 2018. As a family doctor, you get a bit sad because you see your patients about when they hit 40, they start getting sick and you just start giving them pills. And I always thought my job was about prescribing tablets. And so people just end up on more and more pills. And I tried lifestyle. I used to really try and get people to lose weight and did everything that I could, but nothing ever worked. And then one day I stumbled across that insulin carbohydrate model of obesity, which just made so much sense. And I discovered Dr. Eric Westman, who's got that white coat video on the internet. So you can watch that and figure out how to explain it to patients. And so I just started doing that in my practice, and it was incredible. People got better. Irritable bowel got better, diabetes went away, people lost weight. It's like a miracle. It really was a miracle. And this is someone who's been trying everything for years. Nothing else worked like this. And so then, of course, I became a low carb zealot and started putting all my patients on it. And so now that's all I do. I have a practice where I see people with metabolic syndrome, diabetes, chronic kidney disease. So I have a lot of fun because people get well and I'm always stopping medications instead of starting them. So that's me.
Yeah. Quickly, what are the root causes of CKD?
That's such a great question. So, of course, there are the odd things like an autoimmune disease, but the majority of people with chronic kidney disease, the root cause is metabolic dysfunction, high insulin, insulin resistance, high blood sugar. That's really, I think, the root cause of the majority of chronic kidney disease. And look, even in patients, say, who've got an autoimmune disease that's damaged their kidneys, when the kidneys stop working, you actually become insulin resistant as part of that kidney dysfunction. So really everyone with chronic kidney disease, no matter what the initial trigger was, it's driven by insulin resistance. And that's the thing everyone should be targeting if you're worried about your kidneys, in my opinion.
So whether it is diabetes or for the matter even CKD, the standard advice which is given is usually low fat, low protein, low salt, and there is no talk about carbs at all. Now, is it really effective in your CKD patients, or even for the you can generalize to the general population also? And what is the consequence of such standard diet?
It's really, I feel, a tragedy. Really, for the last 70 years, people with chronic kidney disease have been told to restrict protein, and often, low fat as well, because people get heart disease with chronic kidney disease. So they're told low protein, low fat, low salt, probably fluid restrict because they get, fluid, they retain fluid. So the poor things, what are they left with? Bread. And so those carbohydrates, we know, are driving metabolic dysfunction, type 2 diabetes, high blood pressure. We're probably harming people by limiting everything, so they're just left with carbohydrate. And so that low protein advice, I actually think, has probably been harmful for people. And I'm actually really happy because I think that advice is beginning to go away. So now if you look on Kidney Health Australia's website, there's no mention of protein. It doesn't say limit protein. They'll say don't go under 0.75 grams per kilo, but they're not saying go low protein. They're actually highlighting sugar and refined carbohydrates. So there's a real change. And the International Kidney Body that, KDIGO, they came out and they're not limiting protein anymore either. So I think the American body still is a little bit, but they are moving away from that. And that is just good news for people with kidney disease because, guys, you're busy looking at protein. It's get rid of your metabolic syndrome and your kidneys will be so happy. And what drives metabolic syndrome? It's those sugars and starches. It's get rid of your diabetes, get rid of your high blood pressure, lose weight. Don't worry fussing around with this protein nonsense. And honestly, I think when people get right to the end, so say you've got your fistula in, you're going to go to dialysis, it's weeks away, your CKD5, it's the end of the line, which most people never get to. 90% of people never get that far, but say you do, that would be maybe a time where restricting protein might make you feel a bit better and keep dialysis away a few months. Because those proteins they make these uremic toxins that make people feel awful. But for the gross majority of the world, limiting protein does nothing except make you a bit miserable, sarcopenic, malnourished and miserable. That's my opinion. And luckily that's beginning to become mainstream and a real push away from limiting protein.
That's an information. I think I should visit the Australia site and see. It's really encouraging and becomes a reference base for us. Yeah, Anup.
Yeah, I think many developments are taking place in Australia. I think even Diabetes Association, I think they have tied up with the Defeat Diabetes.
Yes,
So
yeah.
yeah, good to get to hear all these developments. Now, for various levels of CKD or stages of CKD, what in your opinion should be the protein intake?
Whatever you like.
Let's say CKD 4, 5.
Look, I don't restrict protein. I would just go moderate. I'd keep myself, if it was me, I'd just go moderate protein. So if you're going on a low carb diet, just up more the fat rather than be upping a ton of protein, would be just like, you know, keeping yourself on your toe in each camp. But I wouldn't even be worrying about it, to tell you the truth. You'd be focusing on when your blood sugar level is doing, and eat to keep that low and eat to keep your weight down. Because the medications that we use, like the ACE inhibitors and the SGLT2 inhibitors, they stop this hyperfiltration that is the theory behind the amino acids being a problem. So, you know, maybe, you know, it probably doesn't matter that much because you're on the drug stopping the hyperfiltration. But if you're a bit worried about it, I'd just go, you know, moderate protein, 1 gram per kilogram. I heard you talking to Dr. Gupta, and he was talking about how in India, everyone's low protein in any case. Would that be correct? So, like, you know, don't worry.
You know, the average protein consumption of this population must be 0.5 gram per kg body weight. It is not even 0.8, which is required for the survival.
Yes, yes.
And then we are made to hear that, you know, restrict your protein.
Even further.
From the mainstream.
What are you told? I just missed that.
I said, you know, we are at 0.5 grams per kg body weight.
Yeah.
National average. And even then, you know, in cases like kidney dysfunction or something, they're told restrict protein further.
Are you serious?
Yeah.
You know, you need to get this great paper that's called Protein Restriction in Chronic Kidney Disease, Time to Move On, by Obeid et al. In the journal Kidney 360. It was published in 2022. And they have a lovely table of all the randomized control trials showing whether protein restriction works. And the best trial ever, super expensive, you know, multi-center randomized control trial, using a really accurate way of measuring renal function. So they use this radioisotope clearance, so not your usual estimated GFR, but an actual measured GFR, every 4 months. And the study went out for over 2 years. There was no difference between the low protein and the not low protein group. No difference. So why are we forcing this on people? So that list is gorgeous. And there's one trial there where they sometimes show a bit of extra time to end stage kidney disease, so time to dialysis, but no difference in decline in kidney function. So the kidney function's dropping at the same rate, but if you're low protein, you can hang out a bit longer, maybe a few more months before you end up on dialysis, just because you're not as uremic. Do you see it? You know, so, but it's, you know, it's just not evidence-based. It's really terrible. So that, I love that great table. It makes it so clear, and they just go through it beautifully. And I really think it's going to change. I do think it's going to change. So you show that to those nasty doctors that are killing their patients. And the thing is, when they end up on dialysis, it's like, oh my goodness, eat more protein, because it's a catabolic state. So it's like, become sarcopenic into your dialysis, enter dialysis really wasted and unwell from your low protein, and then all of a sudden, quick, eat more protein. It just doesn't make sense. It's harmful advice.
And I think rightly so. We are asked to restrict even further, and it's only going to, you know, harm. So you just talked about high protein or higher amino acid. They can cause intraglomerular hypertension, which may cause hyperfiltration, glomerular injury. First, if the patients are on ACE inhibitor or SGLT2 inhibitor, will this be avoided? If they are not on this, will amino acid cause this problem?
So, beg your pardon? So the medications stop hyperfiltration. Okay. So they'll reduce that glomerular hyperfiltration. So the benefit of having less protein isn't really there. Okay. But again, even before those drugs, they didn't show any benefit with low protein in any case. No sort of life-changing difference. It's sort of more almost like a religious belief that you've done your randomized control trial. It didn't make any difference, but let's keep doing it because we really think it's good.
In fact, there was a Cochrane review also on the same. It shows that there was hardly any difference between low protein and high protein. And
Yes.
it is there for everyone to see. Even the study you told is always there. And even I have read it some time back. Anup,
And there is a randomized controlled trial back, 2004, or the one that was carbohydrate restricted, low iron, polyphenol enriched, randomized controlled trial. They had 91 people in each group, went out, I don't know, 2 years, and there was a 40% people on the 50% less carbs did better than the low protein. And so no one's looked at that more. We've got that little trial there that seems to show low carb is good. And there's also a study in Israel. They did a feeding study. It was called the DIRECT study, and they did a calorie restricted, low fat, calorie restricted Mediterranean versus not calorie restricted, low carb diet. Long-term follow-up, 2 years, I think. And they looked at the renal function in those people, and it improved in all of the groups. But in the people with CKD3, it actually improved the most in the low carb group. So there's all these hints of evidence that low carb is good. So we just need someone to do a big trial. And I think Jeff Volek is doing a trial into chronic kidney disease. And I know there's a group in Italy that are about to recruit doing a ketogenic diet looking at chronic kidney disease. So the interest is there, but if you've got chronic kidney disease now, you sort of can't wait, can you, for these randomized controlled trials and for guidelines to change, because that'll be a generation, and it'll be another 50 years. So you just need to look at it. If it was me and I had that problem, I would be low carb. Like Virta Health, do you know the Virta Health trial? They looked at the kidney people there, and 6 out of 10 people with CKD3 improved. Did you know that? Up from 3 to 2. And the higher the ketones, the better they did. So again, there's these hints of evidence everywhere. And of course, you had Thomas Weems from Santa Barbara Nutrients and looking at autosomal dominant polycystic kidney disease. That's showing benefit. There's just all these little hints out there that this is the way to go. That kidneys like low sugar, low insulin, ketones if you've got some, and put that diabetes to sleep. The kidneys are happy. Don't worry about this protein business.
Nope.
While we are on protein, what's your opinion on plant protein versus animal protein in general and with respect to CKD?
So that's interesting, isn't it? Because there's something about plants that everyone thinks are magical plants. So there's 2 aspects to this push for plant protein. One of them is that the plants come with fiber and, your gut microbiome, and your LDL cholesterol is lower on a plant-based diet. So there's that sort of aspect. And I think, we can all agree that meat is pretty great we can see carnivores reverse their diabetes, it's great. So you don't really need those things. Secondly, some plant proteins are less acidic. So patients with chronic kidney disease, about 15% of them, when they get to stage 4 and 5, you'll see their bicarbonate drop and they get a bit of a metabolic acidosis, because the kidneys, they're important for maintaining the pH of your body. And so they're not working so well. So you can get a bit acidotic. And animal proteins, but also grains, are a bit more acidic because of their amino acids that they have. So they're a bit more acidic. So you might find that you need to add a tablet like sodium bicarbonate to get rid of that acidosis. So plants like vegetables and fruits are less acidotic. So you can treat an acidosis by upping your vegetables and your fruit, or you can take sodium bicarbonate. So there's that aspect to plant proteins. But again, remember, grains, they're a plant, they're still acidotic. But it's only, you just give people sodium bicarbonate. So personally, I don't understand why you would be so worried about that. Again, I think it's theoretical. And for those people with late stage kidney disease, if you up the fruit and vegetables, then you bring in more potassium, and often right at the end, They're having to take, they're worried about potassium. And this is why people with chronic kidney disease get in a complete mess, because you're low protein, you're meant to do fruit and veg for acidosis, but that's too much potassium. And it all just becomes made up, not science-based mess. And that is why I feel if you've got kidney disease, just get rid of your diabetes that causes it, your high blood pressure, just keep your eye on the prize. Don't get tangled up with plants versus protein. I really just think it's glycemia, it's insulin. That's what's important.
So what are the precautions should we take when we administer carbohydrate restriction to CKD patients? Do we need to monitor the electrolyte and bicarb? What is your thoughts?
Yes. So it always depends. Like if you CKD3, it's pretty easy, it's not that big a deal. Once you're down to CKD4, say your eGFR is 20, it's a bit more tenuous, and often, what I worry about the most is blood pressure dropping, because when you put people on these very powerful diets that are as powerful as fluid tablets, as diabetes medications, you get big fluid shifts, and the kidneys do not like low blood pressure. So if you've got a fragile kidney, you go on a ketogenic diet, you're still taking your fluid tablet, and your blood pressure drops, then you might actually hurt your kidneys. So that is where I'm very careful. If someone's on a fluid tablet, I will be warning them. I want you to check your blood pressure at home if you can. Tell me what it is. I'll be watching them carefully. And I've had many patients where I've had to get rid of their Lasix, a big dose, within 5 days, because it's a huge change in physiology and they get this monstrous diuresis. So I watch those. That's what I look. Of course, insulin, but we all know that. That's everyone. Watching those, that is what my special thing is for my my kidney people, is the blood pressure, and getting quickly pulling out those fluid tablets so that you don't get that drop in blood pressure. And the other thing is you have to be careful, because I don't know if you knew that with ACE inhibitors and those SGLT2 inhibitors, which are great for kidneys, when people first go on them, sometimes renal function drops a little bit. And it's actually a sign the drug's going to do good things for the kidneys. And Professor Karen Dwyer is a kidney specialist here in Australia. She wonders, when you first put people on low carb, you might just see that little bit of a drop, but don't panic, because then it just fixes itself. So my big thing to watch really is blood pressure. The other thing is uric acid. So a uric acid can go up a bit initially, particularly if you go on a ketogenic diet. Then it gets better, but it can go up initially. And uric acid crystals are not so great for the kidneys. So if someone's got a high uric acid, I do put them on sodium bicarbonate or keto citra, just to keep the urine alkaline. But that's not science-based. That's just me thinking, oh, I'll just watch the uric acid there. But for the most part, if you're CKD3, it's just the usual things that you do for everyone else. It's not such a big deal, I don't think. But you track it. I would do bloods at 1 month and 2 months just initially.
Do you have to measure the electrolytes, potassium, phosphorus?
Yes. Yeah. I've just, in Australia, you just write UEC as like a routine bloods, and you would be getting those at 4 weeks. So I'd be watching creatinine, eGFR, potassium, but you don't really see a problem with those. So it's not so tricky, really. It's meant to be tricky, but it's just watching your person carefully. And the medications, I feel, are the most important thing to be watching.
How about SGLT2 inhibitor?
Yeah, that's great, isn't it? So SGLT2 inhibitors, I used to think, gosh, I must stop them. They cannot go with a low-carb diet. It's against the rules. Ketoacidosis, really dangerous. But I've since looked into it and realized that's actually not such a big worry. So firstly, if you've got chronic kidney disease and you do not have type 2 diabetes, you can take an SGLT2 inhibitor. You're not going to get ketoacidosis. It's seen in people with diabetes, and diabetes with low insulin. So that's the big thing. Do you have low insulin? Are you a type 1 diabetic? Are you a burnt out type 2? So you would measure the insulin level or a C-peptide in these people and make sure they have enough. So make sure their fasting insulin, say, is above 10. Don't miss that latent autoimmune diabetes of adulthood. Don't miss that more type 1 person, because ketoacidosis occurs in people with low insulin who then have a trigger like dehydration. You need both to get this ketoacidosis. So you've got low insulin and then you fast for an operation. That is a trigger, but it doesn't happen. You need both. So if you've got enough insulin and you tell your patient, right, you're an insulin-resistant chronic kidney disease person, you're full of insulin, you're insulin-resistant, you're fine, but always stop it if you're sick. So the sick day management plan is so important. And I feel I've met so many people, no one's ever told them, if you're sick, stop your SGLT2 inhibitor. You know, days where you're not well, don't take it. And honestly, if everyone did that, there wouldn't be a problem with this ketoacidosis. Stop it when you're sick. So I keep it going as long as someone's got enough insulin and they have a sick day management plan. And when I say insulin, it's endogenous insulin, not insulin injections. And there's a cardiologist in Australia who's used SGLT2 inhibitors and low-carb diets in over 1,000 people. And he said he hasn't had one case of ketoacidosis. So if you have chronic kidney disease, they are great drugs. So I would be on them, because I think they probably work beautifully with a low-carb diet, and together they're a really lovely combination, as long as you remember to stop it when you're not well.
Anup, I'll just jump to the question now. What is the benefit have you seen in those CKD patients where you apply low carb? What is the kind of reversal have you seen, like stage 3 to stage 1? Or have you been able to get someone off dialysis or any further advance to lower? How is it?
Yes, I think once you get to dialysis, it's probably too late. Those kidneys are scarred and it's too late. So no, I've never been able to get anyone off dialysis. Hugh Adams, who's a kidney specialist in America, he told me about a person who had CKD stage 5. Their eGFR was sort of 14, and he was getting them ready for dialysis and he wanted them to lose weight. So he put them on a ketogenic diet. And of course, they did beautifully, and now their eGFR is 30 and they don't look like they'll ever need dialysis. So that's the case from Hugh. For me personally, I've seen people whose eGFR is sort of 28 going up to 45. And I would expect your renal function to stay the same. And that's what I expect to see. And certainly all the low-carb doctors I work with often mention people whose renal function's improved. If you've got albumin in your urine, particularly a lot of it, it tends to indicate a poorer prognosis and a more rapidly declining kidney function. So in those people, you'd be wanting to be very diligent with the diet and really following it carefully, but it can still progress. So there are no promises, but certainly I usually see renal function stay the same and often improve.
Have you got anyone out from, let us say, 20, 30 eGFR back to 90?
No, the best I would have got is, well, the lady from 28 to 45. And then there's another lady, she was low 30s and now she's always low 60s, but not that miraculous up to 90, no. I feel there's a lot of inflammation in the kidneys, and that's probably what we're fixing when you go on a low-carb diet. But underneath that, those tiny little tubules are damaged, and they're probably never going to get undamaged. But that's okay. You just want to hold it steady. If you can hold it steady, then, you know, you should be fine.
Anup?
Yeah, the cystatin C versus serum creatinine test.
Thank you so much for asking this question, because I think it's really important. So, and you'll see there in those new KDIGO, you know, KDIGO guidelines, they're mentioning cystatin C. So when we measure kidney function, we estimate it based on creatinine. But creatinine is dependent on your muscle mass, whether you've just eaten cooked meat or even if you've just taken a creatinine supplement because you're a gym junkie. And so there's all these inaccuracies. So we do this formula and it's based on your age and this creatinine level in your blood. So say you're a big Sean Baker carnivore, lift weights, you're going to have quite a high creatinine level because you've got big muscles. So you've got more creatinine because this is in your muscles. So you've eaten a big steak, which puts creatinine in your blood. You got your big muscles. Then you turn up for your blood test and they're going to tell you you've got kidney failure because your creatinine level will be high for your age, and it's a formula. And they'll go, oh, your kidneys mustn't be working well because the creatinine's building up in your blood. You've got kidney failure. And this actually happened to someone I know when they were told they needed a kidney biopsy. But cystatin C is another way of estimating your kidney function that does not depend on muscle mass or what you just ate. It depends on how many cells you've got in your body, how many nucleated cells. So if you're a big muscly person, it doesn't matter. It doesn't affect it. And that's another way of doing it. So if you're a big muscly gym person, I would recommend getting a cystatin C blood test, and then they'll give you a estimated glomerular filtration rate based on your cystatin C, and that'll be more accurate for you. So for example, the person who was told they had kidney failure, their eGFR and creatinine was 52, so CKD-B and 3B, and then they had their cystatin C done and their eGFR was like 115. So they had perfect kidneys. And I'm sure there's a lot of people who go to the gym, eat a carnivore diet, and are worried about their kidney function. And if only they knew just to get a cystatin C, they wouldn't need to be worried. And at the other end of the spectrum, you've got the little old lady with no muscles at all, who probably thinks the kidneys are terrific, but she's got no muscle, no creatinine in her blood. So it sort of makes her look like her kidneys are terrific, but actually they're probably rubbish. It's just she hasn't got any muscles and gives her this falsely high GFR. So particularly for gym people, I think you need to know about this cystatin C blood test, which you can just ask your doctor to order. It's, available from the pathologist. In Australia, you have to pay for it, but it's definitely readily available.
Is cystatin C associated with uric acid in the sense if it is slightly off the mark, will it be due to presence of higher uric acid or is it independent?
I don't think it has anything to do with uric acid. Not that I've read.
In India, we see that, cystatin C, and then they also add this uric acid along with that. So I was very curious to know whether there is some connection between these two.
Yeah, I don't know. I haven't read that, but I'll go and read it now.
I think that's one good way, because we have a eGFR calculation via cystatin C also, other than the standard creatinine one. So very, very interesting. And your talk on low carb down under was very inspirational, and I learned a lot. I saw that, and I told Anup that we should have Dr. Penny in our program, because the way you talk, the lot of information you gave, and we may want to discuss more, probably because of time doesn't permit. We just
I'm so sorry.
Doesn't matter. I think we have covered well. And
yes, I think so.
We had Dr. Alok Gupta with us a day before.
Yes.
We had Dr. Thomas yesterday to talk on PKD and yours. So thank you very much. So Dr.
Thank you so much for having me.
Before we go, what is your message to India?
My message is keep your eye on the prize. It's low carb. Keep your insulin down for your kidneys and your blood glucose down. Don't worry about protein plants. Don't get messed and confused. It's about metabolic health. That's the most important thing for your kidneys. Thank you so much.
Thank you.
Lovely to meet you.
We will have you again in our future events, or we might invite you for our internal podcast to learn much more about the work you are doing in this space, because there are many other points which we may wanted to discuss due to paucity of time. But I think this becomes very important in the sense that today India is having 100 million confirmed diabetics, 126 million pre-diabetes, and the kind of kidney function damage we see in India is terrible, because we as health coaches, we come across all these cases where they have been having uncontrolled blood sugar, uncontrolled blood pressure, and then it whacks the kidney. That's what it impacts the kidney very hard. And then we cannot do anything when they come to dialysis stage, but the other stage we do take care. Personally, I have success stories of reducing from stage 3B to stage 1.
Have you really?
Yeah. So I do take care of these kinds of cases. They have associated BP and blood sugars. We apply low carbohydrate and maybe not ketogenic, low carb, and then we get it very nicely. We have a lot of such success stories, not the extreme cases, but yes, the early stages we managed to reverse it nicely to not crossing that 90 EGFR, but coming to that small. In fact, day before yesterday, we had one case where one of the doctors showed that the EGFR increased from around 62 to 87. So these are kind of success stories. So thank you very much, Dr. Penny, and we'll see you again. Anup.
Okay.
Thank
Bye-bye.
you.
Thank you so much.
Bye-bye.
Bye-bye.
Thank you, and we'll see you again. Thank you very much.
Bye-bye.